This is part 3 of common emergency room cases. We shall focus on ocular trauma. This is Dr. Darby Santiago, your lecturer for tonight. The objectives of this lecture is to enumerate and differentiate the various clinical presentations of ocular trauma with special focus on corneal abrasions, foreign body, perforating injuries, intraocular foreign body, globe rupture, and orbital fracture. It is also our objective to understand the management rationale for each problem that we are going to encounter. Ocular trauma has a very wide range of presentation in the emergency room. It can be as simple as a scratch, or it can be as bad as an uh, as an ocular rupture. So careful history taking should be done among patients who present with a chief complaint of trauma to the eye. So let's start with a simple corneal foreign body. Usually, the patient would complain with foreign body sensation. It's like they're feeling a grain of sand inside their eye. The pain is usually sharp, and sometimes, if there's an abrasion of the epithelium of the cornea, the patient will report to you photophobia. Now, what are the signs that you see? The most common is your conjunctival injection and eyelid edema. The conjunctival injection is due to the reaction of the conjunctiva to the inflammation that is happening on the corneal surface. If you have to check for abrasion, and you can do so by checking at the corneal surface consistency. If it is smooth, the reflection of light on the cornea should be also be sharp, no, smooth. However, if the cornea reflect light reflection on the cornea is granular as such, then you might suspect some distortion or some abrasion that is happening on the eye. This photo shows you the staining of the epithelialized corneal surface. The corneal foreign body is easier to detect, no? So you just need to shine a bright light and look for foreign objects such as these metallic, rusty speck of foreign body. If the patient comes to you with trauma and he is all teared up, could barely open his eyes, what you do is check for the visual acuity first. If it's okay, then you can put a drop of anesthetic. You can either put proparacaine or lidocaine, your regular, so that the patient will be comfortable while you examine him. Use a strong light. Okay, if you see, you have to flip the eyelids, both the upper lid and the lower lid. You check the fornices for foreign body, and if you see foreign body, then you may try to remove them using your forceps or a cotton swab. You may also use a needle, a tip of a needle, but you have to place it sideways. Okay, point it directly to the foreign body. You might puncture the skin or the cornea itself. After removing the foreign body, if you feel that there's going to be an infection of the surface, then you may give topical antibiotic. Any broad spectrum antibiotic will do, tobramycin, moxifloxacin. However, if the epithelialized area is very small, then you may just opt to observe and not to prescribe antibiotics anymore. The surface epithelium will heal on its own. If you cannot remove the foreign body, or if you feel that you are not competent to remove the foreign body, you can just refer the patient to the nearest ophthalmologist in your area. Now, what if the patient complains that something went into his eye, so it's still a foreign body? If he presents like so, then you have no more problem, no? You just leave it there, the foreign body, have an x-ray done, and then refer the patient immediately to an ophthalmologist. However, if there is no more nail or any foreign body poking the eye in a perforate, you have to further examine the eye to check if there is indeed perforation or if it's just a simple foreign body. So the major signs, symptoms of perforated eye is sudden decreased vision and pain, severe pain. A very important question that you have to ask is if there was fluid that flowed out of the eye when the injury happened. So that will be telling that the aqueous has flowed out or tama ba yung spelling? Aqueous or your vitreous. Okay? What are the signs that there is a perforating injury? Well, you may be able to see a full thickness scleral or corneal laceration, a severe subconjunctival hemorrhage is also telling, shallow chamber, and irregular pupil will also indicate that there is perforation of the eye. Most of the patients are male and children, and the injury happens during work or at play. Sometimes there is assault or accidental trauma also. If the injury is perforating, the intraocular structures are usually involved. Structures like your lens, iris, vitreous, retina, no? And they often lead to endophthalmitis and blindness because you are introducing bacteria into the eye. Now, what are the most common causes of perforating injuries in the Philippines? Um, we have banned or tried to ban barbecue stick in children's parties. We have also advised teachers about the use of scissors in the kids' bags. Walis tingting is a very common material used in children when they do use this as a projectile. No? Uh, Among workers, nail heads are a common source of penetrating injuries to the eye. If your patients come from Baguio or the Cordillera, um, dynamite shrapnels are common among the miners. No? Firecrackers also, and gun blasts. Okay. You have to be astute, no, in identifying whether there's a corneal injury or not. Sometimes the patient will come to you and this is what you will see. Grossly, this may look like a small insect or a part of an insect that is on top of the eye, but the patient will complain to you that something hit his eye. This is actually an iris prolapse, no, and with the formation of cataract there. The other picture, the one on the right, shows you an old penetrating injury to the eye. The corneal scar is over here. Okay. What you see is an irregular pupil. It is peaked this way because during the injury, the pupil, the iris, uh, tried to go out, no, of the lacerated area. But the corneal laceration fortunately healed itself, leaving only a irregular pupil and cataract formation. You have to differentiate irregular pupil due to uveitis to that of an irregular pupil due to an old perforating injury. The picture on the right, shows you a metallic foreign body inside the vitreous, on top of the retina. No, it entered. This foreign body is a projectile that could have entered through the cornea or through the sclera. Okay, this probably entered through the sclera because a picture was still a very nice picture of the posterior pole was still taken, meaning the cornea is clear and meaning that the lens is not yet cataractous. Okay. For 20 years now, we've been complaining about the quality of the nails that are being distributed in our local hardware. They are of poor quality, and the nail heads are usually easily get chipped off. So this is a hazard for our carpenters actually. How do you further detect scleral perforating injuries? These are examples. Sometimes you see the patient comes to you complaining of in foreign body hitting the eye, but you don't see anything in the cornea. The cornea looks okay. And then you see at the side of the white sclera a black material. No? That's already your uvea. Okay, that's a uvea protruding, and maybe you will be able to see some vitreous prolapsing. Okay. Another picture on the left is a limbal scleral laceration. No, this is the limbus, and this is the scleral part of the laceration. Okay, and you see iris prolapse. The iris is continuous to this one. Okay, so there is a correctopia, irregularly shaped pupil. You have to operate on this, close this, and operate on the eye immediately. All right. Now, those are from the simple foreign body to perforating injury. Now we go to globe rupture, which is more serious. You will see here on the left side a picture of a patient with an anterior globe rupture. You will see here a mucoid mass, which when you try to remove or clean the area, you cannot remove. No, it seems to be connected to the eye. That is already your vitreous that has prolapse. This area here is a dried up uvea. No? It is impossible to save the vision of this patient's eye, and most likely you need to enucleate or eviscerate the eye. The picture on the right shows you a very nice cornea, and you can see here that the corneal reflection is sharp, no? Meaning there is no aberration of the corneal surface, and you can see the pupil to be round and not disturbed, no? LP. You will have, but you will notice, no, that the conjunctiva is full of blood underneath, no? This is your subconjunctival hemorrhage, severe. This sign is very important because it will indicate to you that there is a rupture behind or at the back of the globe. So we put this eye as a presumed globe rupture. This is common among blunt injuries to the eye. Okay. So if there are globe rupture, what do? You protect the eye with an eye shield. Usually, it's a plastic thing, no, or a conical shape plastic, hard plastic to call just a makeshift cone to cover the eye. No, you don't use a patch. Why? Because you might exert pressure on the eye, and the remaining contents might go out. You determine the nature of the trauma and the extent of the injury. You have to give anti-tetanus regimen immediately and start your broad spectrum topical and systemic antibiotic therapy because you presume that bacteria has been introduced inside the eye. We should avoid manipulation or further exploration of the eye, and just after putting this cone, send the patient to the nearest ophthalmologist in your area for proper management. What if the patient is hit in the eye with a blunt instrument like a baseball bat, or encountered an vehicular accident and hit the eye in the steering wheel, no? So you suspect that there is an eye globe, orbital globe fracture, no? And you're suspect. What do you ask if you're suspecting an orbital fracture? Uh, you will see that there could be. You ask the patient if he has diplopia and if there is local tenderness in the area. You examine edema and ask the patient to move the eye and check for pain on eye movement. Also, other signs would include restricted eye movement. There can be enophthalmos or sunken eye, such as this case. There could be subcutaneous emphysema because of subcutaneous air coming from the sinuses, and infraorbital hypesthesia. This eye, the left eye is on upgaze, but you observe the right eye, it is looking forward. This one, there is an attempt to look up, but not as much as that of the left eye. So you check for EOMs, extraocular movement, globe displacement, and check for sensation of the V1 and V2. Palpate for subcutaneous emphysema, and palpate the orbital rim to check for discontinuity of the rim. This is your step of deformity. Order for a plain CT scan of the orbit, both axial and coronal cuts. You may be able to you have to look for the teardrop sign, which is the protrusion or the herniation of the orbital content into the sinuses. What do you do if if you confirm that there's an orbital fracture? You give a cold compress every 2 hours for 20 minutes in the first 48 hours. This is to reduce the edema so that you can better assess the fracture and the effect on the globe. Give broad spectrum oral and IV antibiotics. Why? Because you assume that there is bacteria from the sinuses entering the orbit. Refer the patient to an ophthalmologist, more specifically to an orbit specialist. Because if there is evidence of muscle entrapment, surgery must be done within 24 to 72 hours. This will prevent the permanent formation of fibrosis in the prolapsed area. Most of the time, surgery is delayed until the edema around the eye and in the orbit has subsided. And we do surgery only when there is persistent symptomatic diplopia, when there is a really large orbital floor fractures, and if there is an enophthalmos of more than 2 millimeter, resulting to a cosmetically unacceptable appearance. So those are the only indications for orbital surgery later on. So in summary, we have discussed the recognition and differentiation of the clinical presentations of various orbital trauma to the eye, from foreign body to abrasions up to orbital rupture and orbital fracture. I hope. Thank you.